Now, the newer packet that I gave you, again, you have to know these. So if you look at this packet, there's a lot of drugs in it, and it's going to cover you for practically speaking everything. What I would say to you is if I add it, it's important. I've categorized these in the way we use them. Okay, let's start with the top line in the first place. Every patient on an antihypertensive med, you're going to be teaching them to rise slowly, which is at the top. Never quit abruptly, because what could it cause? Hypertensive crisis, says it right here. Okay? Otherwise, you have to, if you don't rise slowly, you could faint because you're dizzy. It's all written for you. Everything is written for you. Now, this drug may affect libido, and your laypersons call it a cock blocker, so you know your patients are fun. So they're going to say, I don't want that shit, you know? Okay, and so it can affect your libido. Some of them are very easy to change if that's your patient's issue. Remember that many of the drugs vasodilate, so taking a shower with really hot water for longer than 5-10 minutes, they're going to bottom out. They're going to hit literally the shower stall floor. So why? Because warm water vasodilates. What does vasodilate do? It lowers the blood pressure. They already took a drug to do that. Now you enhanced it. Okay, so it's absolutely absurd. So you want to remember that all of these drugs have an effect on the human body. Okay, now beta blockers, I can tell you to highlight atenolol, metoprolol. I want you to understand how this drug works. It's going to work on the nervous system, specifically the sympathetic nervous system. It's going to block epinephrine and the stress response. Here's our problem with the stress response. You and I both know a stress response is called fight or flight. And when you're in a fight or flight mode, you release this substance, catecholamines. This is epi/adrenaline. Same shit, different day. So epinephrine is adrenaline. Adrenals. So in our endocrine lecture, on our endocrine lecture Monday, we talk a little bit about adrenaline, adrenal function. This type of chemical helps you cope with stress response of fight or flight. It'll either help you run real fast, adrenaline, or it'll help you fight real hard, adrenaline, okay? The only problem with adrenaline, which is a whole nother word for epinephrine, is that these catecholamines vasoconstrict. We don't like that, so we give a beta blocker. A beta blocker is going to stop the catecholamines. It's going to block this fight or flight response. So therefore, the patient will not have catecholamines with the stress response. These are your beta blockers. That's a good thing, because when you were crunked up and ready to fight, ready to run, either one, you were real tachycardic. And tachycardia makes the heart work too hard. So if this drug is blocking the stress response, which included tachycardia, you better remember that it actually will give you a bradycardia. These drugs slow down the heart rate, and that's a good thing, but on a bad day, that could be a bradycardia. So we say hold the drug if the heart rate is less than 60, sort of like we do with DIG. Hold the drug if the heart rate is less than 60. The last thing you need to be giving your patient is a beta blocker. Now look who they're contraindicated in and highlight it. Asthma/COPD and diabetics, yes? Okay, so you got to remember that. Now let me tell you why they are actually, and you don't have to write this, you just have to understand it. In the diabetic, they don't cause low blood pressure, they mask blood pressure. They don't cause low blood sugar, they masked it. Remember what happened with your diabetic in 1600. When a diabetic's blood sugar dropped, they kicked into stress response with tachycardia, sweating, tremors. This is blocking the stress response. So the patient themselves, including you and me, we don't know your blood sugar low, you don't have any symptoms because it blocked it. So it's masking it. So literally this patient could have a low sugar, they wouldn't know it, I wouldn't know it unless I tested the sugar, and this allows for it to go even lower because it didn't know it. Okay, so that's kind of like what it's kind of confusing, but I hope that helped. Okay, now, take home messages. Atenolol and metoprolol. Examples of beta blockers. Going to decrease the heart rate. Going to block epinephrine and norepinephrine. You have to know that. You can't be goofy. Okay, so it's like a big deal. Now, tachycardia, I just want to make sure you're clear. Tachycardia increases the workload of the heart. If I give this patient a beta blocker, it'll decrease the workload of the heart by just decreasing the heart rate. Okay? Now, ACE inhibitors, we talked a little bit about that. We said it prevents the A1 becoming A2, and because you prevented angiotensin 1 from becoming angiotensin 2, you also blocked aldosterone. We said it worked on both preload and afterload, didn't we? Okay, so here's the deal. Think that through. This is the drug of choice for CHF. This is the #1 drug of choice for CHF. In a patient that has had a heart attack, it decreases their risk of CHF the next 24 hours. The #1 side effect is that dry cough. And if that's true, what do? Switch them to an Arb. Switch them to an Arb. The #1 drug in this category is lisinopril. So far, so good? Okay, now calcium channel blockers. The calcium channel blockers actually move back and forth in the heart to cause the heart to contract. When we use a calcium channel blocker, the most important thing I can get you to remember is #2, and that is that it dilates the arteries only, not the veins. It doesn't do a damn thing for veins, so it's not the greatest with patients who have right-sided heart failure, because right-sided heart failure was venous. Remember that? It was a venous issue. Okay? Now, so here we do. This is what we want you to remember for your exam. You want to remember it slows calcium movement across the heart. So it slows conductivity. It slows conductivity, which makes this the perfect drug for dysrhythmias. #4 has dysrhythmias. Y'all see it? Okay. AFib and A-flutter. #1. Particularly for your exam, the most common drugs, verapamil, cardizem, highlight those, they're already there. Verapamil, cardizem, It says amlodipine is Norvasc. Norvasc. Highlight it. Y'all see it? Okay. So Norvasc, verapamil, cardizem, boom. Procardia is also important. Procardia is there. Okay. Now, so here's what we're doing, y'all. You remember we said Raynaud's was arterial, Berger's was both, but a lot of artery, intermittent claudication. That's what calcium channel blockers treat, all three of those. So peripheral vascular disease, PAD, PVD, remember, same shit, different day? Okay, examples, the three that are there. This is your calcium channel blockers. They treat that. Because why? They dilate the arteries. When you use a calcium channel blocker, you cause smooth muscle relaxation. Smooth muscle relaxation. This ends up being vasodilation. Smooth muscle relaxation is vasodilation. Okay, guys, turn the page. Let's go. Chop, chop. The next category is your Arbs. I want you to highlight Cozar, and I want you to write in that this is losartan. I'll put it up here. Every Arb ends in sartan. Every single Arb ends in sartan. They do similar actions that the ACE does, except it blocks the receptor sites. So look how I spelled all these drugs out. I said angiotensin II receptor blocker. Honestly, they will be spelled out. So you have to know this is going to block the receptors, whereas the other drugs, the ACE, prevented the conversion of one to the other. Now, this is obviously just as good as the ACE inhibitor for the diabetic, okay? I want you to put for both ACE and Arbs, so maybe you can say ACEs and Arbs, watch the potassium. Watch the potassium. These drugs are your best bang for CHF and CVA, stroke. CHF, CVA. Now, the risk of the ACE inhibitor was angioedema. And this drug does not give you the cough. So there's no cough here. This is what we use to substitute. They're more expensive, but you still do pretty good. Okay, let's keep it moving. Diuretics. That's easy. Bumex and Lasix. Look what they put. Furosemide. Look what I put. Furosemide, right? So you know that's important. Then you had to know loop diuretic. So highlight loop diuretic. Number 4 is important. Prevents sodium chloride reabsorption in the loop of Henle. Number 1 looks like a nice select all. When you have a loop diuretic, it lowers your potassium, your sodium. It takes the water out of the body, but it can raise the blood sugar. The number 1 indication for these drugs, the top indications for these drugs, I'll just give you a symptom because you'll need it later. Pink frothy sputum. What was that? Pulmonary edema. So pink frothy sputum, i.e. pulmonary edema. CHF. You can see number 2 tells you the rest of them. Give it with OJ or tomato juice because you're wasting your K. Apple juice doesn't have any potassium in it. Okay, continue on to aldactone. That looks suspiciously like aldosterone, doesn't it? That's why you care about it, because it looks a lot like aldosterone. Aldactone, aldosterone. Aldosterone in the later half of the medication look like what? What did sterone remind you of? And what do steroids do? They make you retain sodium and water. Do they make you retain potassium? Not at all. So when we look at aldactone, which is spironolactone, this is actually a potassium sparing. In fact, I tell you to remember that spironolactone spares the potassium. So potassium sparing. Now, that's important. It's still a diuretic, so that's good. But it does not take your potassium away. And so since the liver patient is always low in their potassium, this is a good drug for cirrhosis. Under number 2, highlight liver disease. So if your potassium is lower than 3.5, could I give the aldactone? Yeah, it doesn't have any effect on potassium. Could I give the Lasix? Never. Okay. All right. Now, HCTZ, hydrochlorothiazide. You probably know that drug if you've been alive longer than 15 minutes. Everybody's on it. I want you to highlight report blurred vision and follow, or not highlight, but write it. Report blurred vision and follow electrolytes. Oh, I know what else I wanted to tell you. I wanted to tell you about the aldactone does not work in the loop of Henle. It works by blocking the reabsorption of sodium and water in the distal tubule. So don't worry, I'm going to say that again. Aldactone works by blocking the reabsorption of sodium and water in the distal tubule. It does not work in the loop of Henle. Absolutely does not.